Thank you very much. And now it's Irene Berger telling us about the risk of false positives PSMA PET. And we discussed it yesterday. It's not only applicable to biochemical recurrence, but also for the initial staging. So let's have a look where we can be fooled by avid lesions that are not prostate cancer.
Thank you very much for the invitation and the kind introduction. And it's an absolute pleasure, of course, now to shed some light on how we can discover those false Waldos. These are my disclosures, but I think they are non-relevant for this talk. So as Jochen already stated, I'm not focusing on the prostate PET alone. I think there, of course, positive urine is the false positive. And Professor Vargas is going to cover this topic afterwards with what MRI can do. But let's look into the prostate, the nodal lesions, the visceral lesions, and the bone lesions, and try to figure out how best we can navigate around those potential false positive lesions. In the prostate itself, I think zonal anatomy is absolute key. We need to know where we are. Is it the transition zone, is it the peripheral zone, or is it the central zone? The interpretation of uptake needs to be completely different. And that's why I really am so glad that we have primary score, and I would hope that we get away from those SUV cutoffs, please. It matters where you are. The transition zone, if it's diffuse, if it's homogeneous, then that's nothing. You can also have inflammation, strange lesions that are really suspicious, but it's very rare. And in the central zone, this can be very PSMA positive. The Mickey Mouse ears can be hot on PSMA PET, and it's not a cutoff. I've had central zones with an SUV of 16. So that would be primary 5. It's not if it's the central zone. To navigate this, I really deeply recommend stick to the primary score and look where you are. If you are more than double the contralateral side and focal in the transition zone, it's a score 3. If you are in the periphery, no matter how low you are, if you are above background, it's a 4. And if you are above 12, it's a 5. If you're not in the central zone, because the central zone, if it's symmetric at the back, you should not consider suspicious. If you stick to this, you're quite good. You're slightly better even than multiparametric MRI. And your inter-reader reliability is even higher. So I think it's a promising tool if we know what we look at. Now, nodes makes it a little bit more difficult. Here we have, again, 3 potential pitfalls. Ganglias, inflammation, and of course, secondary primaries. Everything that's hypervascular can be PSMA positive. Now, how do we handle this? For the ganglias, I think it's anatomy, location, and morphology. You need to know where you are. If your lesion is below the vertebral, behind the vessels, let's see whether that works. Oh, not so much. Okay, so on the first image, this is not a lymph node. This is not supraclavicular lymph nodes. They would be anterior to the cervical vessels. If you are around the celiac ganglia around the truncus celiacus, very often they have a so-called teardrop shape. So this, again, it's not a lymph node metastasis. It's benign. And also presacral ganglia, a very common pitfalls. You have to know about them. Now, sometimes you have very strange lesions. And here, schwannomas, neurinomas, can also be a big pitfall. If lymph nodes follow the lymphatic drainage, if you have very odd locations, think about what do you typically have in this area. In this case, I just show you, behind the scapula, lymph nodes, really? When I saw this case, I ordered an MRI with the request, is there a schwannoma of the axillary nerve? The radiologist came back to me, so how do you see this schwannoma on an unenhanced CT? Well, I didn't, but it was PSMA positive, and it's the area where you have a nerve and usually not a lymph node. So always think about neural structures if it's not matching nodal locations and if it's not matching also the disease spread of your patient. Now, the second primary lymph node metastasis. Here, this is your job. You need to give us the information what the patient had in the past and also how risky this disease was. So we need to know the history to be able to make a difference, whether this could be rectal cancer, renal cell cancer, anal cancer. Also thyroid cancer can cause, of course, supraclavicular lymph node metastasis. You easily can mistake them for prostate cancer metastasis on a PSMA PET. So anatomy, morphology, location, and history is helping us. Now for the visceral lesions. Here it's even trickier. I mean, hemangiomas, sarcoidosis, secondary primaries. To be very honest, most often it's maybe a little bit the morphology that helps me for interpretation, location, likelihood of metastasis, but at the end it's a biopsy you will need. These two cases, the patient on the right side had a rising PSA after prostatectomy, 1 lesion in the frontal lobe. I was convinced this is a glioma. I don't see the disease. It was a prostate cancer metastasis. You can't tell. The other lesion, I thought first, oh, that's a liver thing, so not so likely to be in an early biochemical recurrence situation. It was a lesion around the ligamentum falciforme. It was a peritoneal metastasis from prostate cancer. So here you really need the needle to confirm. That brings me to the big hot topic and probably the most difficult one, the bones. We have benign lesions like hemangiomas, Patch's disease, degenerative disease, fibrous dysplasia, or fractures that can be PSMA positive. We also can have second primaries like osteosarcomas. This is super rare, and I had really to dig through the internet to find one case. And then we have the unspecific bone lesions, the so-called UBUs. So for the benign lesions, sometimes morphology helps, salt and pepper structure. For hemangiomas, fractures, you can see. For the second primaries, super rare, you need biopsies. And for the unspecific bone lesions, I think we could fill several talks about how to handle that and how to get around it. How do I do it? I first look at the tracer. What tracer did I use? And I'm so glad Ursula just pointed that out twice yesterday. You need to know if it is a gallium PSMA 11 or a PSMA 1007. Why? 1007 is excreted over the liver more than the kidneys. It's more lipophilic, and it has more. You see here 50% versus 12% or 20% unspecific bone lesions. Unspecific bone lesions like the PSMA RADS3 lesion. So it's not very hot, intense uptake, and no morphological correlate. And this is a very pretty picture in this first paper that pointed out the differences between the traces. But to be honest, in daily life, they look like this, or even like that. So what are you doing with this hot lesion in the rib? We tried, or we learned, that we have to ignore all the PSMA RADS3 lesions very early on. And then I'm very grateful for the work in Bern, because they went in with the whole body PET scanner and really did biopsies targeted on those positive lesions in the PET scanner to be sure you were in the lesion. And they were all negative. So you have to skip even the PSMA RADS4 lesions and consider only PSMA RADS5 if you have 1007. Now, suddenly everybody tells me a lesion is nothing if you don't have a morphological correlate. And as Stefano Fanti always points out, that's reversing the pyramid of logic, because PSMA is more sensitive than CT. And if we dig through the PSMA gallium data, we see that especially in biochemical recurrence, most of the lesions have no correlate, and still nearly half of them are malignant, based on a reference standard. It's not published yet, unfortunately, just submitted. So I think we definitely need to have another reading system, and if we look at gallium PSMA 11 or Pylclari, then stick to PSMA RADS, and 4 and 5 is suspicious. So with this, I would say for bones, you need to know which tracer you look at. 1007, consider only PSMA RADS5, meaning intense uptake and a correlate. And for the other tracers, go with 4 and 5, intense uptake, with or without correlate, and the PSMA RADS3 only for biochemical recurrence in some selected situations. Overall, for the prostate, you need to know the zonal anatomy. Lymph nodes, again, you need to know anatomy and history. Visceral, you need to have a good interventional radiologist to do a biopsy. And bones, as I just said, stick with PSMA RADS5 for 1007, and for the other traces, you can go with 4 and 5 to not miss the bone metastases that were actually present on your image. And with this, I'd like to thank my team and you for your attention.